Our next presentation will be focusing on inpatient MOUD services and addiction consult services, and will be presented by Gresha Eberly and Dr. Cara. Gresha Eberly is a woman in long-term recovery from a substance use disorder and is a public advocate to destigmatize addiction treatment in healthcare settings. She has used her lived experience to educate physicians in training at Michigan State University by sharing her story with them and during their addiction medicine intercession. She has been featured on several media outlets, including Spectrum Health's Spectrum Health Best and Fox 17's Beating the Odds. Gresha worked as a recovery coach with Spectrum Health's Inpatient Addiction Consult Service and is currently the project manager for the Heart Initiative. She has a passion for helping those who struggle with addiction to live their best lives, the lives they were meant to live. Dr. Cara is a recognized expert in addiction medicine. She is a faculty member at Michigan State University. She earned her medical degree from Wayne State University and was trained in internal medicine at St. Joseph Mercy Hospital in Ann Arbor, Michigan. In addition, in addiction medicine at Boston Medical Center in Boston, Massachusetts. She received her master's degree in education from Boston University. She has an interest in educating healthcare providers and providers in training to improve care for patients with substance use disorders, particularly during pregnancy and early parenting. So I'd like to welcome my colleagues and friends, Gresha and Cara.
I'm the loudmouth that's been sitting over there, but I was told apparently people couldn't hear me, which I think I'm going to mark this date in my agenda and make sure I tell my significant other that statement, because I don't think he's ever thought that in his life. So I was asked to repeat a couple of things I said earlier, so I apologize if you did hear me, but I'm gonna go for it. The first one was around peer recovery coaches. There is some discussion, it's pretty early at the state level, around certifying and recognizing peer recovery coaches. So there are opportunities for us to get engaged in those types of conversations. What isn't in my bio is I do chair the Michigan Society of Addiction Medicine Advocacy Committee. Dr. Lane is one of our members. We are always eager for more members and more opportunities to build coalitions to support some of that work. The next piece of that was talking about the alternative payment opportunities that are through direct Medicaid. So if you are an outpatient provider, and this does also include hospital-based outpatient providers, we did get clarification on that, then you can actually bill directly through the CHAMP system, so as though that individual has straight Medicaid. A lot of our billers then have come back to me and been like, you know, you're confused because it either goes through their HMO or it goes through the PIHP system, but this is a separate carve out. There is a memo. You guys have that if we need to share it, right? Okay, we'll make sure that gets out to the team. But what that covers is that covers E&M billing, so outpatient, new patient codes, outpatient follow-up codes, and then it covers only alcohol use disorder, and opioid use disorder does not cover stimulant use disorder, and I was told that's because there are no medications for that. It does also cover, yes, that's a point of advocacy as well. It does also cover counseling services done in an outpatient-based opioid or outpatient-based addiction treatment service. It covers laboratory evaluation. It covers collaborative care. It covers case consultation, lab work, urine toxicology. Dr. Lane, am I missing anything? Okay. Sorry, just needed to phone a friend for a second. So that is available for people who are not affiliated with the PIHP, and that does allow for some additional reimbursement opportunities. The next question I always get about that is, as a physician, right? I mean, I'm sure this happens in the ER too, right? People come in with one complaint and only one complaint. And so you bill the entity of their primary diagnosis. So that's where it becomes important for us as clinicians to be marking. In Epic, it's the blue diamond, which one is primary, because if it is the substance use disorder stuff, then it goes to the CHAMP service. If it is depression, it goes to their HMO. If it is diabetes, it goes to their HMO. So that primary diagnosis is really key to that. Associated with that, as part of what Gresha and I are going to talk about with inpatient services, we have worked again with the Medicaid group, and they've been fantastic. I don't even know, like, this happened in within 6 months. It was crazy fast. But these services are now expected to be covered by their HMO products. So inpatient addiction consult services are now officially a covered benefit from Medicaid. So I feel like that deserves applause, because it hasn't been covered for forever. And I'm so thankful to our colleagues at Medicaid for just kind of saying, wait, that doesn't even make sense, so we're gonna expedite this, because that one that came out August 5th of 2001, I started advocating for those changes in January of 2014. So 6 months is like lightning speed. It doesn't always feel like it, but we've come a really long way here in the state in terms of what is a billable service for Medicaid, and I just want to acknowledge it. It's not that we don't have a lot to do. It's not that we don't need to have recovery coaches recognized, but I think we also have to be respectful that sometimes these things take more time than any of us in this room feel like we have, or like we want to see it take. So where we can, count our wins, hopefully we can work with Medicaid, work with the DHS to support moving some of this forward. There was one more, wasn't there? Oh yes, the Opioid Advisory Commission. So on the side, in my spare time, I also chair the Opioid Advisory Commission. We are a legislative entity that is over part of the opioid settlement dollars, so there are both state and local allocations. The state allocations, the Opioid Advisory Commission gives recommendations to the state legislature about how those dollars may be appropriately used. It is my understanding that not all of our legislature is even aware that we exist. So my ask to you all is to go to the OAC website and send a letter to your state representative and your state senator, making some noise that the OAC exists and asking them how they would like us to interact with them. Because without that feedback, I'm just writing reports and sending out information into an abyss, and I don't know if it's actually helpful for legislature. So that would be really, really helpful. On the OAC website is our annual report, which came out in the late winter, early spring. As well as 2 additional FAQ documents that just came out in the last couple of weeks. And those FAQ documents were a collaborative was done through a collaborative work group, and those are also available, and I think each one's 4 or 8 pages long. So they're a little bit shorter, a little bit more digestible, and they were done across all 3 branches of the government participated in those work groups. So there's lots of key answers, who do you contact for questions, and then finally, in terms of the local settlement dollars, we are fortunate to have Amy Delinky in the back of the room, straight kind of in front of me. She just raised her hand. She is with Michigan Association of Counties through some funding through Bloomberg Vital Strategies, and is available to provide technical assistance and support to individual counties in terms of how they might appropriate these dollars, facilitating needs assessments and things like that. So a very great resource for the local dollars on the MAC website is also a beautiful, just breathtakingly beautiful, the most wonderful piece of artwork you've ever seen in the form of a dashboard. on how the dollars are being used, what's being allocated to individual communities, that may be helpful. Amy also has a wealth of knowledge in terms of contact people for different both counties, municipalities, as well. So another fantastic resource related to those opioid settlement dollars. Now remember that those opioid settlement dollars have an 18-year cliff. We are through year 1. So again, with the sustainability talking, but this gives us lots of time to work with our colleagues across Health and Human Services to try to figure out how we're going to do this differently, how we're going to do this in a sustainable manner, and how we're going to get those recovery coaches funded, right? As kind of a key piece that's come out repeatedly today. Okay, I think I did everything I was supposed to. Okay, now we're going to talk about what we actually are here to talk about, right, Gresha? Okay. Gresha and I have been together for like 10 years. So she's stuck around. I don't know what's wrong with her. So I don't know, what was it, 2017, 2018? I had these like 3 random ER docs, like all simultaneously reach out to me. One from Detroit, one from Hurley and Flint, and one from Sparrow and Lansing. And I was like, all asking me about this addiction stuff. And I was like, how about you 3 just talk to each other? And 2 of the 3 are here today. So I feel like, so they refer to me as the Yoda of addiction medicine. So here I am as Yoda. I almost brought, my son has like one of those pillow pets that's a baby Yoda. I almost brought it to put it in the chair next to me, but I didn't know if other people would like get the joke. So I am here as Yoda. So it's really been amazing and remarkable to watch them grow. One of them is like this tall. So it's really been fun to watch this program grow and to be able to be a part of it. As sort of an analog to this, we started the consult service on January 4th of 2020. That was good. And then we had our recovery coaches as well as our therapist hired in mid-February of that year. So everyone remembers what happened in March of 2020, I think. So we started this inpatient consult service through funding from Michigan Health Endowment Fund and through the Michigan Opioid Partnership in order to try to start an inpatient addiction consult service. And so now we have a continuation grant from Michigan Health Endowment Fund in which we try to support hospital-based services that want to do inpatient-based addiction treatment. Hence all the work with Medicaid to support finding a pathway for payment for that. We are able to customize the work. So some larger systems like Henry Ford in Detroit have a more robust addiction consult service, maybe a little bit more formal of an entity, whereas some of the smaller hospitals, like we've helped some of the Munson hospitals with kind of training hospitalists and working through not necessarily creating one giant service, because if they don't have a cardiology service, they probably aren't going to be able to sustain an addiction service, right? So how do we build that capacity in smaller communities? And we've done this in large part in partnership with Michigan Hospital Association, who helps us connect with many of the hospitals, as well as with the Community Mental Health Association, sorry. None of us have any financial disclosures, so we're going to kind of talk a little bit about what we're doing, this is all the stuff I've already said. That's me. You've met me. This is Dr. Trowbridge. He and I went to med school together. We started med school 19 years ago because I'm officially old. And he and I sat next to each other in med school in the lecture hall, and they were not assigned seatings, and now we still work together. Isn't that kind of fun? It's like one of those moments. So he actually helped launch the initial addiction consult service at the Boston Medical Center, and he is widely published on the topical area and serves as a peer reviewer for many of it. He's also boarded in infectious diseases, and so that's often a primary team that we're partnering with in hospitals, or that is often a conduit into addiction care as well. You got a wonderful introduction to Gresha as well. She is She is an amazing advocate for persons in recovery, and I've asked her to just start by telling a little bit of what her experience was when she walked into an emergency room and when she was treated in the hospital as a person with a substance use disorder.
Thank you, Dr. Poland. Like Dr. Poland said, we've been working together for almost 10 years because I celebrate my 10 year in recovery in October. Part of the reason why I started doing this work is in 2001 is when my substance use disorder started after suffering the loss of my first child. They didn't have very many resources back then, 10 years ago, for people like me who had lost a child. So I just started using opiates. I went to a doctor and he prescribed me some painkillers and it was off and running. So that lasted for about 13 years. Towards the end of my substance use disorder, I started having seizures, which brings me to one of my points. It's actually a story. I'm more of a storyteller than a speaker. But in 2010, I was in a sporting goods store, and I had two of my babies with me and my husband, and I was holding one of them, and I just remember bending down and standing back up and everything blacking out. That's when I had a seizure, a pretty bad seizure that cracked my skull open and caused bleeding in the brain. The ambulance took me to the nearest hospital, and from there, I would think, the doctors would help me get better, because they knew why I had a seizure, and that was benzoyl. So if there had been an inpatient consult service there, that weekend I probably would have started my recovery journey a little bit earlier. At that point, I had no idea that I was so, I'm not going to say far gone because you're never far gone. At that point, I think I was ready, but I didn't know what to do, and I didn't have the resources. So I got released from the hospital with a pretty hefty stack of prescriptions, and I just continued on doing what I was doing. I started my recovery journey in 2013 after a couple tries in an emergency room. I would go to the emergency room and be discharged feeling hopeless, despair, like nobody was going to help me and I could not receive any help if the hospital couldn't help me. What am I going to do? So I just kept using until I finally found a little hope, and that was at a clinic in Grand Rapids where Dr. Poland worked. And I started medication for opioid use disorder, and here I am. I've been working in the treatment recovery field probably since my own recovery because, like everybody says, it's a passion. I think when about a year into my recovery, I felt that fire inside of me, the fire inside of you that just wants to help make the change. So I started working with Dr. Poland, educating medical students about stigma and stigma within the healthcare system. So that brings me to HEART. We're going to talk about more of the inpatient side. HEART is hospital engagement addiction resources team. So what are you going to do when they're in the emergency room but they end up getting admitted to the hospital? That is where HEART comes in, or the addiction consult services. So things that we do, we can, to get to the next slide.
Sorry, I didn't
I'm
tell
sorry,
her.
I didn't
It's
know
my
about
fault.
the remote. I'm just standing there looking at my picture. So,
There you go.
thank you.
And then it's down there, but I couldn't see that because I'm short.
That's why they call you Yoda. So, obviously, we all know why treating SUD is so important. So, it's obviously the public health crisis of our time. It's the first time in U.S. history that that people have died younger than their parents without a war being involved. I thought that was a pretty impactful statement. Illnesses, including substance use, liver disease, and suicide. Economic cost is comparable to cardiovascular disease. My dad went through some heart conditions last year, and just going over the bills with my mom is incredible. The cost is insane. It's not just an opioid crisis, but alcohol, stimulants like Ritalin and Adderall, I see a lot of. And deaths from alcohol have always been higher than from opioids and are rapidly rising. So why is hospitalization a reachable moment? And I think Jake Mantefelt may have said this earlier. If they're not ready when they're inpatient in the hospital, a consult service the recovery coach, or, they can plant the seed. If you can just plant the seed of recovery, then they'll come back. I've had more than a handful of instances when I was on the consult service in 2020 where the patient wasn't really ready. They knew they should. They were in the kind of ambivalent. So I just gave them the information that they needed to know. So a couple weeks later, they would call me and say, I'm ready. There was at least 4 instances. So I think planting the seed is just as important as, giving them the resources or starting them in treatment. Because a lot of times they don't want to start right away, for different reasons. But there will come a time where they're ready to start. Do you want to talk about the key elements?
Sure. So yeah. Do you want it back or do you want me to finish?
No, you're fine.
Got to make sure I follow her expectations. She's the boss. All right. So, we need medical providers. Really, the early models of addiction consult services focused heavily on the medical providers. So you can run a service with just medical providers, so providing the prescriptions, providing the medications, providing linkage. And then with those types of services, we're often relying on the general social work or discharge planning staff to support that. So if that's the route that we need to go in a hospital system, we want to make sure that that team, or at least their leadership, are engaged in the planning process so that they know that they're going to get more consults, and it's not okay to just hand them a list of AA meetings, that there's a little bit more to it than that. If we're talking about alcohol use disorder, that we want to make sure that they understand that the patients are offered medications, that we're trying to get them a little bit more heavily engaged. And then of course, I think the Detroit Medical Center team was talking a little bit during the last panel about embedding some of these follow-ups into the EMR, rather than having to be, call this number to the access center and stuff will happen. Because that's just not what happens, right? So we worked really closely with our Community Mental Health Authority in Grand Rapids, which is Network 180, and what I said was, okay, you guys, I want you to just pull up your pregnancy policy and do a find replace. Everywhere where it says pregnant, put hospitalized. And that's what I want you to do with my hospitalized patients. What does that mean? By state law, we have 48 hours to get a pregnant person into treatment. And that gave them 48 hours on discharge to get somebody into treatment. Magic happens. right? We eliminated the access center like questionnaire by actually hiring our therapist through the CMH. It was so successful that they just decided that they didn't need to have that 2-hour-long phone call that somebody referenced earlier today. So we have direct access in Kent County, in part as a result of that work. So for all my patients, not just the inpatient patients, they no longer have to call the access center. We can just link them with some of our community resources that are funded through the PIHP system, which is fantastic because it removes a ginormous barrier. We can also, as the hospital, call and say, hey, I started Jane Doe on methadone at 30 milligrams. They're going to be discharged tomorrow. Can they get a new patient appointment at the methadone clinic the following day? And again, magic happens and it goes because the policy is now such that if they are in the hospital, they are treated as though they are pregnant. And so they've got 48 hours to get that person in.
We usually got them in the next day.
We usually got them in the next day, I'm being told. But that also, and then we also worked with the state authorities to determine that if somebody had a prolonged hospital stay, think, injection, drug-related infections that require 6 weeks of antibiotics, that they would also, that we could titrate up that methadone dose if methadone was the right option for that person, so that we could, and when they went to the methadone clinic, they didn't have to start over again, which previously was what happened. So we worked, we tried to work with all these different partners, so when we designed HEART, we made sure we had Michigan Hospital Association involved. We made sure we had the Community Mental Health Association involved so that we can kind of make, I call them love matches. So we can make love matches between the hospital systems and the community mental health so that we can try to break down some of these barriers that, that make it difficult. Because I have yet to find either a hospital system or a community mental health that has all of the answers. None of us do, right? And so we're stronger if we work together. And that's really been our experience with HEART. And then key to the success of them all, maybe I should put it in bold, is hospital administration. We were told that we weren't going to be able to start the consult service, and then I went to the president of the hospital, and guess what? I had a meeting with her on December 23rd. And we went live on January 4th. Do you know what happens between December 23rd and January 4th? Nobody's around, right? Those of us that are clinical care were there, just ignore that statement, but none of the administrators are around. But we made it happen because she said, I want this to happen. And when the president of the hospital says it has to happen to the hospital staff, guess what? It happens. We really built ours around a prescriber, behavioral health, and recovery coach, but we've really been able to show that you don't need every single one of those individuals. You can work with what you have in your hospital, work with a hospitalist, get them some confidence, help with things like protocols and whatnot to ensure that people have the support that they need to be able to do this. We are like ED MOUD light, so just be aware that we have an order of magnitude less funding than they do. I'm just gonna throw that out there. So we don't have the funding to pay y'all to do this, but we will support in whatever way we can to make it happen. We also worked with a lot of the outpatient medication prescribers outside of the methadone system, and we mentioned ways that we can help with billing for that, but also shout out to my Michigan Opioid Collaborative colleagues toward the back of the room. But we are regionally throughout the state of Michigan and able to help connect people to local options if you don't know them in your community, and then we can also support new prescribers who are interested in starting to do this on the outpatient side, and lots of collaboration with local harm reduction organizations. I think most of the EDs now have Narcan distribution directly from the ED, so working to ensure that people have access to that from the inpatient side as well. So I mentioned all of this. We're going to just skip some of that because we talked about all this. So again, we'll help with individual prescribers or groups of prescribers working on the inpatient side, and then in terms of like helping to develop and sharing protocols or recommendations from both a more regional as well as a national standpoint, because some of the payment systems in Michigan are relatively unique. So making sure that you know that we get paid for the work that we're doing is important. So we have created protocols that, you know, please take, copy, cut, paste, and then use them or customize them for your system. We do know that inpatient addiction consultation works. We know that when somebody is in the hospital, just having somebody give the recommendation that somebody drinks less for somebody who has risky drinking, not a substance use disorder, but risky drinking, results in a reduction in alcohol use over 6 months. It's totally feasible to start medications for the treatment of a substance use disorder in the hospital. It's actually like really easy, especially like now that I'm old. People like have started buprenorphine in the past. Like in the olden days when I first started this, we'd have them like come to the clinic and we'd have them get into withdrawal and then they'd be like, here's your buprenorphine. Right? It was like this mystical experience, and now I'm like, hey yo, have you used Suboxone before? And they're like, yeah. And I'm like, okay, you can tell me when you're ready? And they're like, yeah. I'm like, okay. Do you want a prescription? Go, right? If they're outpatient, if they're inpatient, you know, I just, like the protocol says COWS score of 8, or when patient says they're ready. It's like magic. It's so much easier. And then, of course, methadone being a full agonist, you can add it pretty much at any time. So we do see that inpatient addiction consult services are associated with higher rates of abstinence and lower addiction severity post-discharge, and more engagement in SUD care, and a decreased rate of readmission. I feel like that speaks to administrators a lot, because that decreasing that 30-day readmission is like a key thing, and there is concrete evidence, there are citations there, that it does just that. So that's a really key one for when you're talking to administrators. And then lower rates of readmission, as well as lower rates of emergency department use. We are here to help. There's our citations. I thought we had Gresha's contact information up here. We have flyers on the table. It's like in the second one from the left and standing up in the front, I think. So if you would like to get in touch with us, obviously, they have all our contact information as well. And I think I left time for questions, right? Thoughts, questions? Rotten tomatoes for me. And can I just say thank you to Gresha for sharing her very personal story again? Yes.
Thank you for presenting and sharing this with us. For a hospital or hospital setting that doesn't have the HARP program, and most have psych consult, they call it, if they have a patient. Are you aware, are there best practices in how you deliver that sort of bedside assessment? I mean, there are certainly ASAM sort of docs with accreditation and training, but for those psychiatrists who are not specialists and are encountering a patient, is there a manualized, how you keep it person-centered and kind of do the risk reduction, harm reduction kind of activities? You're not ready for treatment, but just kind of an overall assessment and sort of that intervention at that level. Are there guides for this stuff that you're aware of, or that you all might replicate this?
Yes, there are. So we have presentations that will come in and work directly with the hospitalist-based team to help them understand how to talk to patients. We do a lot of talking about stigma and addiction, the kind of the words we use, how we approach this patient population. And when you were in kindergarten and you learned to keep your hands and feet to yourself and be nice, I tell people we're going to work on some of those skills just with this patient population. It goes a far way just being nice to people and treating them with kindness and compassion. And so that's, if you wouldn't say, I took out the slides on diabetes in this presentation where I'm if we did what we do with addiction care and we did that in diabetes, if somebody left the hospital without a prescription for insulin, that would be malpractice. letting somebody leave the hospital without a prescription for an FDA-approved medication to treat an alcohol use disorder or an opioid use disorder, that's malpractice. It should be. And so we need to encourage people to look at it through that lens, but also, you don't say to somebody, like, can everyone here that's a clinician think in their head, don't shout it out loud, HIPAA, but can we all think of like the person that is a frequent flyer in the emergency room because of uncontrolled hypertension, uncontrolled diabetes, uncontrolled chronic illness X, uncontrolled asthma? When we look at, when we use a chronic disease model to look at the treatment of substance use disorder, the relapse rate in asthma, in diabetes, in hypertension is not different than that of substance use disorders, but somehow we look at it as different. So when we talk to clinicians out in the community, we try to use that kind of chronic disease lens and really pull that thread out. And so, can we all name those people? Yes, we can name those people, whatever disease state we're talking about, right? And we need to change it from those people to how can we understand what's going on with them? Can we learn to use motivational interviewing when talking to our patients that have diabetes, when talking to our patients, right? So how can we make some of the skill set, how can these skills, because I'm not going to speak to everyone in the room, right? You've all had to try to engage other ED colleagues, right? And you've got the people that you're like, oh, this person is not engaged and this person is highly engaged. So how can we broaden the interest by bringing maybe some of these other chronic diseases into it and talking about it in terms of how do we address chronic illnesses more broadly, and how can we kind of make that similar here, and how can we empower you to feel like you're doing something more? Because I don't know about the other doctors in the room, but we're an arrogant group just overall, and you know what we really like being? We really like being the smartest people in the room, because that's what we're used to. And so when we walk into the room and our patients know more about the disease of addiction than we do, it doesn't feel comfortable for us. And so then we put on our own masks, we put our own judgment and stigma onto them because we feel insecure about what we know and what we're doing. And that's something that we have to address through teaching, training, and education. Soapbox, I'm sorry, I'm gonna fall when I try to step down, break my leg. Good thing there's a bunch of ER docs here. They'll be able to set my femur back. Well, people leave the ER through one of three ways: the morgue, the door, or to inpatient. So if you don't have inpatient treatment, they're just going to come back to your ED. So send your inpatient providers our way.
Thank you.
Thank you.
I'm standing between Bob